Welcome. My name is Jasmine Kamboj, and I'm a medical oncologist and hematologist in the state of Minnesota and your host for the day. Empowering Oncologists is a podcast brought to you by OncoDaily, where we will focus on day-to-day concerns of an oncologist's being and workflow, with a vision to find sustainable solutions. We hope to share our stories of wins, losses, resilience, and inspire and empower our community because we fly longer and higher when we fly together. Before we dive in, a disclaimer. The views shared on the podcast are an individual's and in no way are contributions from any institution, organization, or guidelines. According to the data from the U.S. Department of Health and Human Services, there are more than 5,000 radiation oncologists in the United States. These numbers continue to increase, and as we all know, oncology is a multidisciplinary field, and there is not a day that passes without me touching base with my rad-onc friends and colleagues. Lord knows they're one of my closest friends at my practice, and they work so hard, and I cannot work without them. For our session today, we have Dr. Samir Keole, who practices as a radiation oncologist at the Mayo Clinic in Arizona and has served as the president of American Society for Radiation Oncology, ASTRO, for the year 2024-25. Passionate about advocacy and policy, he has served as the ASTRO's Political Action Committee chair of the Government Relations Committee, and the ASTRO board. He is also an avid volunteer with ASCO, and I see him at the Advocacy Summit every year. When not working, he loves to hike, play golf, and stay connected with friends both within and outside of medicine. Dr. Keole, thank you for being here and welcome.
Oh, thank you for having me. I've been looking forward to this for a while.
Beautiful. Samir, tell us about your journey. You've traveled the world. You've done so many things, so many wonderful things across your career. Please share your journey with us.
Yeah. So, it's like many, it's been a long time in the making. Ironically, we're recording this on a day where I am not in my own office, but rather the office of a colleague, Hermanos Cancer Institute in Detroit, Michigan, where I trained. I'm a visiting professor here today. And
Wonderful.
so I completed my training in 2004 and was fortunate to get engaged with ASTRO right away. And that was on the government relations track and eventually ended up 19 years later being elected to the ASTRO presidential track in the summer of 2023. But all of this really started when I was a resident. I was always interested in advocacy, and ASTRO at that time had just started its advocacy days, and I went to the initial ones as a resident, and then from there formally joined the GR committee, and also became involved in health policy. One of the interesting things I did was serve as chair of ASTRO's Political Action Committee, as you may know. But what may be of interest to a lot of your members, since I assume they're ASCO members, is myself and David Adler, who's director of advocacy for ASTRO. We actually made, I think, one of the pivotal pitches to the ASCO board, I believe in 2019 or 2020. My memory's fading a bit, on the role for advocacy as they were deciding whether or not to start a political action committee. And that I think ended up being successful. So I had a small role in advocating for the role of ASCO in this process. And so I've been involved with that. But so that was kind of where it started. And that's how I ended up becoming ASTRO president. But as you noted, I'm still very engaged with ASCO as well.
That is so good to hear because I did not know that backstory behind ASCO's PAC. And that's how we met for the first time, which was ASCO's PAC. And we had Dr. Balaban yesterday, who is the current ASCO PAC chair, last night for our community of practice on policies as a guest speaker. And he was talking about ASCO PAC. So thank you for your efforts with ASCO. That's wonderful. Samir, so you have been, pivoting to the ASCO question. You have been such a strong advocate and involved with policy with ASTRO and ASCO. How has it been for you to volunteer for ASCO as a radiation oncologist?
I think they're markedly different organizations, but
Mm-hmm.
also overlapping in so many ways. I think
Mm-hmm.
fundamentally they're the same. ASCO and ASTRO advocate on behalf of its members so they can take better care of the patients that they serve, regardless of where they may be. So in that
Mm-hmm.
sense, there's a lot of alignment. But obviously, ASCO looks at, I think ASCO, I was told by Cliff, is a roughly 60 to 70% medical oncologist, but it's not 100%. So it's an all-encompassing tent. Obviously, for ASTRO, we're different in that our physicians are almost entirely radiation medicine physicians. We also have radiation physicists and radiobiologists engaged in the society as well. But
Wow.
fundamentally, I think we do a lot of the same things, and that's we try to figure out how do we serve our members so they can serve their patients better.
Absolutely. And that's such a great point because as you pointed out, fundamentally both the organizations are working for several bipartisan issues which are centered around patients and are related to cancer care and how we can better provide our patients and serve them better. So thank you for that. I do want to circle back on what you said earlier, Samir, which is you started advocacy as a resident. So was there like a mentor in your residency program? Because I don't think a lot of us, at least back then, used to get mentored about advocacy and policy as trainees.
Oh, great question. I've always been interested in this. I mean, even going
Mm-hmm.
back to high school, I guess I had an interest. I was involved in youth and government. I was actually president of my high school class
Mm-hmm.
when I graduated. So I guess I had always an interest in service and giving back. But I guess I was fortunate to be at a program that really fostered this and encouraged it and didn't
Mm-hmm.
view it as distracting from training, because I think actually it's very complementary. But a few
Absolutely.
things I think that really got me going. Obviously, ASTRO was welcoming to its trainees. It still is, very similar to ASCO. But I also got involved in the Michigan State Medical Society when I was in training. And I think state advocacy, state medical societies are a great place for trainees to get engaged. There's a big drop off in the AMA when you go from the medical student section to the resident and fellow section and the young physicians section. And there's
Mm-hmm.
really, you can learn so much. And so I think it was really helpful for me because I saw a bigger picture than just radiation oncology or oncology as a whole. And so I really would encourage uh, trainees and young members. It's great to get involved in societies like ASTRO and ASCO, but don't forget about your county, state, and and national medical societies, because there's a lot of value there as well.
Wonderful points there because each time we connect with other cohorts of our healthcare professionals, we learn something new and we better understand their perspective, right? Like I was recently in one of the Mayo training stuff, and there was like a pediatric neurologist, there was an ER physician, and there was a family medicine person, and each one of us was giving a case scenario, which is difficult to communicate to our patients. And their scenarios were so hard. I'm like, thank goodness that I'm an oncologist. Even though we brag about how our conversations are so difficult. I mean, can you imagine telling a child and their entire family that they have like Huntington's disease and that's going to impact their quantity and quality of life? Oh my
Yeah,
gosh. What yeah. So it's
no,
great to
it's
learn from others' perspectives.
yes, I agree 100%.
Dr. Keole, so as med-oncs, I feel like we do sometimes, have our own bubble. We have so many issues and we are, constantly trying to navigate our challenges in clinics and settings and hospital settings. What are some of the radiation oncology challenges?
Yeah. So, the casual listener may not be that familiar with, how we get paid. Broadly speaking, there's two payment systems or
Mm-hmm.
two schedules. One is called the Medicare Physician Fee Schedule, often
Mm-hmm.
called MPFS, and this is sometimes called non-facility or freestanding. And then there's the hospital setting.
Mm-hmm.
It's called Hospital Outpatient Prospective Payment System, or HOPS, and that's hospital based. And so we are a very technical specialty, as I'm sure everyone knows, and our technical charges are far greater than the average specialty, about 50 to 60% higher. So we really depend on the valuations, especially our freestanding members that come from MPFS. So just broadly speaking, there's if you get paid on the technical side, so that's for the daily delivery of radiation, for instance. If you're in
Got
the
it.
hospital setting, HOPS sets that, and that's linked to Medicare. I mean, that's linked essentially to inflation on an annual basis. And then, but if you're in a freestanding setting, it comes through the Relative Value Update Committee, the RUC, which is owned and sponsored by the AMA. Professional services are actually set through that process and vetted by the CMS, or we call the agency, and they apply to both settings. So why
Mm-hmm.
is this important? MPFS operates under budget neutrality, and because of that, we've had significant decreases in reimbursement in the freestanding setting of over 20% since 2016, and this has made it since 2006. Excuse me. And so this makes it very hard to operate a small business. And so what we're seeing is closing of practices and increased consolidation, which is, I'm not always sure, in the best interest of the patients because sometimes it decreases choice. So we're really trying to work hard and advocate for our freestanding members. And, I'm proud to say, uh, we're taping this on towards the end of November, and
Mm-hmm.
we've had the final rule come out for the freestanding setting, and we achieved a major milestone, and it's
Mm-hmm.
really foundational. CMS agreed to move the technical component of radiation therapy delivery
Mm-hmm.
from the MPFS and align it with the hospital outpatient prospective payment system.
Got
This
it.
is going to be good because it's really going to stabilize our freestanding practices, and we think it's going to be best for patients in the long run. So we're very, very happy about that.
That's exciting. That's exciting. So two questions to circle back. What exactly is budget neutrality? And how long did you take, or Astro take, to get to this? Uh,
Great question. So budget neutrality is a concept that came about in the MPFS when it was set up back in the early 90s. So for
Mhm.
those of you who don't know, and there's certainly places to get more detail, but
Mhm.
we went to this resource-based relative value system of payment.
Mhm.
This was determined in the 80s based on a Harvard study led by Professor Shao, HSIAO, if the reader wants to look that up more, and as eventually became codified in two sets of legislation, one signed in 1986 by President Reagan, and then the second signed in 89 by President Bush 41. And as a result, this new schedule went into place in 1992, but the problem is it really didn't account for the fact that the budget would have to go up. And so as a result, the pool of money for freestanding center has not gone up really since 1992. So if you think about it, we got paid $31 per relative value unit. That's called the conversion factor in 1992.
Mhm.
That $31 has only grown as of today, November 25, to $32.36. So
Yeah.
4% over the last 33 years.
Mm.
If you just followed inflation, that $31 would be roughly $70 today. So we've lost more than 50% relative to inflation over the last 33 years in medicine, especially on the freestanding side, and that's due to budget neutrality. The pie just doesn't get bigger.
Got it. Got it. This is so critical for all of us to understand, right?
Yeah.
Because if we don't have these freestanding clinics or radiation units or medical practices, medical oncology practices, there's lack of choice, there's lack of access. And I had a good grip on the concept that we haven't kept on the inflation. And so we are like short by 30 to 40% since 2000s. But I did not understand exactly what the budget neutrality concept behind that was. So thank you for explaining that.
Oh, thank you.
Dr. Keole, we have heard a lot of buzz about ROCR. We in Minnesota also supported this last year. Please tell us what exactly is ROCR and how has ASTRO been advocating for that?
Yeah, thank you. So rocker, and we call it rocker because
Hmm.
it sounds kind of cool and it's easier to quicker to say.
Hmm.
So rocker stands for the radiation oncology case rate,
Hmm.
and it's legislation right now, and it stemmed from really in 2015 we were going to take a pretty precipitous cut in the
Hmm.
freestanding environment of approximately 20%, which was going to be
Hmm.
unsustainable. So
Hmm.
we lobbied to get a temporary fix. And as a part of that, in the legislation at that time, it was called PAMPA, PAMPA was the abbreviation, if someone wants to read more. But uh, there was a l- language in the legislation not to create an alternative payment model, but rather to study the creation of an alternative payment model. And so an APM in this context, and this was going to be done by the Center for Medicare and Medicaid Innovation, CMMI, is okay, let's figure out a different way to pay doctors or pay the providers. And so in that setting, it was okay, let's pay by a case rate. So kind of let's stop paying by a taxi where the meter's running and switch to an Uber where, you click on the app and you pay a fixed price and they're going to get you from point A to point B and you've agreed on a price in advance. So it's kind of
Right.
rocker is move. And so the first version wasn't successful, but it got retooled and it got created as rocker and was introduced in 2023.
Uh-huh.
And rocker we like for several reasons. Um, it's agnostic to site of service, but it also pays a fixed rate. And this is important because we've gone to what's called hypofractionation.
Yeah.
And that's using fewer number of days of radiation, which
Mhm.
is great for the patients when used appropriately, but it does lead to significantly less reimbursement, which has put
Mm.
additional downward pressures on the business aspects of these practices.
Got
So
it.
we think that this stabilizes the field. And one of the key things is we're trying to remove, especially the high priced items out of our field from the Medicare physician fee schedule. So you asked me, how long did it take to get MPFS, to take the technical component out? In all honesty, I'm not sure it would have been on our radar a few years ago, but as a component of Rocker, it did include taking the technical component out, the MPFS, and linking it with hospital market basket pricing, which is linked, and we said that makes a lot of sense. So that concept really gained steam in Capitol Hill and with the agency. And I think
Mhm.
without Rocker, I don't think we would have seen really this foundational victory for the field of radiation, where we removed the technical reimbursement for external beam delivery from the MPFS and linked it to the HOP schedule. So that's how it happened. So it conceptually began about 10 years ago, but really took on gained momentum in the last 2.5 years after we introduced Rocker.
Got it. Got it. So one advocacy effort actually kind of like pushed the momentum for the other advocacy effort.
Yeah.
So again, all these efforts are interlinked as well. So that's great.
100%.
Dr. Keole, so as medical oncologists, we are always, being the primary care physicians also, for so to say, for some of our patients, right? Because we see them so frequently. Needless to say, with immune therapy and so many new toxicities, we are becoming immune therapists and cardiologists too, I feel. What about radiation oncology? Are there any non-oncologic interventions that you guys do?
Yeah, that's a good question. And in all honesty, I think a lot of medical oncologists do.
Hmm.
They help manage non-oncologic conditions quite a
Hmm.
bit. For
Right.
instance, you know, NMDA, like anti-NMDA receptor encephalitis,
Mhm.
it's a B cell mediated process and a lot of time needs rituximab. It's not uncommon that a physician that needs to manage
Mhm.
such a case who doesn't have a comfort with rituximab is
Right.
calling their friendly
Mhm.
medical oncologist or hematologist to help
Right.
manage that. So
Right.
I think it happens across the board. So the therapies we offer sometimes can
Mhm.
benefit a variety of patients. So in
Mhm.
this particular case, we started noticing there's been a long history of using radiation for non-malignant diseases. And so I decided to make this a theme of not just my presidency, but also the annual meeting. And it was about how can we reimagine our role as radiation medicine physicians, and how can we help patients with radiation, whether they have a malignancy or a non-malignant condition. So I'll give you three big examples. For osteoarthritis, there seems to be a role in appropriately selected patients that we can both help manage pain and potentially decrease knee replacements with the use of radiation therapy. The data, admittedly, is somewhat still is fledgling and weak. We just had a positive phase 3 study presented at this year's meeting, but we need more data. And so we're trying to help provide a framework for this. There can be some patients with severe dystonias, and there was a very compelling session at our symposium this year on a woman who really had a difficult time even speaking because of disarticulations and difficulty controlling their tongue. And when they mapped this out, there was one area in the brain. And so the team that did this, led by Marcus Bradell, he's an expert in this, and he's at University of Miami, they gave a dose in excess of 130 gray in a single fraction, but it worked. And the pre and post images and videos were really profoundly impactful. And finally, there's a growing trend to try to use single dose radiation for medically refractory arrhythmias. And, this has really been pioneered by the group at Washington University, and now is again the active study of clinical trials being done globally. And the concept is some of these patients have arrhythmias so profound that there's really no medicine that's working. No ablation has been shown to work. And they're so afraid they can't leave the house. And so they did an initial pilot study published in the New England Journal of Medicine about 10 years back, showing 5-for-5 control. And these were patients, I think it was almost like a compassionate use study.
Yeah.
So I think that those are the kind of things that we think that there's a role for radiation that can help patients, but they're not malignancies, but they're certainly very significant conditions.
I had no idea that radiation could be used for osteoarthritis or arrhythmias. This is new to me. All right, Dr. Keole. Moving on to our next topic of discussion. Artificial intelligence. A lot of hoopla around artificial intelligence, some excitement and some fear. What is your take on AI in radiation oncology?
My take is it's coming, and to a certain extent, it's been here for a while. And as you know, and maybe the casual listener to this doesn't know, is that this is a lot of my day job now, where I do spend substantial time evaluating AI applications in all of medicine, not just oncology or radiation. This is something that's a big focus at Mayo Clinic. But relative to this, I think that we've been using it in radiation for quite some time. We've been using it to what we call auto segment or auto contour normal tissues like the liver and the kidney when we're radiating in that part of the body. I think what you're going to see it do is hopefully augment us so we can spend more time focusing on patients and spending more cognitive efforts on complex, high impact clinical questions. So for example, and get to that N of 1. That's our goal, right? In a lot of this research. Internal and external validity. Yes, there's clinical trials, but they don't always apply to the patient I'm seeing in front of me. And so how can we take that body of evidence, look at historical practice trends and outcomes and apply it to that patient right in front of us? And I think that part's exciting. We can do it better with better tools. I'll give you one quick example, and you've seen this example used at Mayo Clinic, but we have new leadership in neurosurgery in Rochester, and they wanted to our new chair wanted to look at our patients treated for glioblastoma. And she had a database of her own. Within a few minutes, she was able to create a database that was 3 times larger using some RAG methods, and found an interesting observation that lamotrigine actually significantly increased survival at every time point up to 5 years post-diagnosis. And then we validated that in the second data set. And so we have to figure out why this happened, but these are the kind of insights you can get that's very that sometimes you can't really do on your own.
For sure.
But with the aid of artificial intelligence, it can really help us think about the same questions differently and more broadly. So that's why I'm excited about artificial intelligence.
Absolutely. Well, we just, at a very basic level, we just started using AI tools in our clinic for documentation, and it is seamless. It is wonderful. It saves me, I would say, 5 to 10 minutes per patient. So it adds up at the end of the day.
Well,
Yeah.
yeah. And more than saving time per patient, you can be that much more focused on the
Mhm.
patient. You can look
100%.
at the patient, you're not looking at the computer screen. And so
Yeah.
even if you saw the same number of patients in a day,
Right.
that's a huge
Right.
victory because that
Yeah.
connection you can make with the patient is that much more.
100%. Absolutely. Dr. Keole, one advice you would give to yourself of 10 years ago?
Oh boy, that's a good question. You know, Not a whole lot, but I think, I'm an empty nester now. My wife and I are empty nesters. Our son is in his second year of college, and our daughter's in her first year of college. And I think we always told ourselves, yeah, that day would come, but it
Mhm.
comes faster than you think. And so,
Mhm.
and it's not just about having kids. I know there's plenty of people that may not have kids, but it's that, life. Before you know it, life, you blink and 10 years have passed. And so
Mhm.
it's easy to always think ahead and think about the next step, but just stop for a second and just appreciate your situation. I would say if you wake up and you can smell the air and you can go to work and take care of patients, it's a pretty great day. So just take a moment and be appreciative of that and be
Mhm.
appreciative of who's around you because you've got other people in your life
For
that I'm
sure.
sure are special, and don't forget to tell them how important they are.
Oh, that's so sweet. That is so
Yeah.
sweet.
Yeah.
All right, Samir. On to a rapid fire. So it's the
Yeah.
fun part.
Yeah.
Your favorite book?
Oh, my favorite book. Probably my favorite book and definitely most impactful, Checklist Manifesto by Atul Gawande. I think it's a must read. I also really enjoyed Walter Isaacson's biography on Steve Jobs. Not that I agreed
Uh-huh.
with anything in it, but the way Jobs thinks is very
Hmm.
interesting.
Yeah. What is the checklist manifesto about?
So the Checklist Manifesto was, I think, published in 2009.
Mm-hmm.
And it's really impactful.
Mm-hmm.
Atul Gawande is a well-known surgeon and
Mm-hmm.
author from Boston. He's in the Harvard system, but he's written several bestsellers. But
Mm-hmm.
that was literally about how you create checklists across a variety of fields, from the
Uh-huh.
surgical operating room to what they do on construction sites to how it works
Yeah.
in planes, and how these checklists need to be short and concise. We have a tendency not just to have note bloat in medicine, but just policy after policy, and they get longer and longer. And he really makes a compelling case that um, you've got to make, if you're going to do this, you got to do it in a way that's pragmatic, and everything should be certainly on one piece of paper, ideally front page only, but make it simple, easy, repeatable steps. And so that's the concept, and I took that with me and I've applied it in
Mm-hmm.
radiation. So how we
Mm-hmm.
create checklists, for instance, how we evaluate plans and
Mm-hmm.
everything. I think it really improves consistency and quality.
Wonderful. Your favorite leader?
My favorite leader, great question. Oh boy. I need a second here. I'm going to go with somebody within Astro, and he'll be surprised if he listens. He's going to listen to this, named David Byer. He's in just a really smart guy, classic. He went to MIT undergrad and was brilliant, could have done a lot of different things. He
Mm-hmm.
established an incredibly prolific career in private practice, but also was academically incredibly productive, has a full professor's CV despite not having that full university support. But
Mm-hmm.
very good physician, but always looked at things in a very thoughtful, methodical manner. And so
Mm-hmm.
he was on the board my first time I was on the board. And I always said, so I actually, a lot of times, if I have a difficult situation, I'll call him and just say, hey, David, this is what's going on. What do you think about it? So he's a guy I really admire from his ability to take a complex and challenging situation, break it down piece by piece in a digestible way.
Your favorite study? A trial or a cancer study?
Oh, it's not in cancer at all. It's the Gusto
Mhm.
trial.
Okay.
So yeah. And so the Gusto trial, for those of you who remember, was a trial of TPA versus streptokinase done in the 90s. And I believe it was done in Italy, and it was roughly 40,000 patients. The details are a little bit foggy to me because for the casual reader, these are not pre-planned questions. These truly is rapid fire. But the Gusto trial was a randomized study between streptokinase and TPA. And there was a 1% difference, I believe, in survival that favored TPA, which doesn't sound like much, but in a 40,000 patient randomized trial, it was statistically significant.
Right.
Europe continued to use streptokinase. We switched to TPA.
Yeah.
Why is that important? It just shows how you can take the same exact trial, interpret it different ways, and how quality adjusted life years and cost effectiveness factors into things. And that trial just really, to me, said this is a big difference between different health systems. And so the Gusto trial for me is always one I bring up.
Yeah. Is there a cost difference between TPA and streptokinase too?
At the time, yeah, I believe it was eightfold difference. So TPA was eightfold more than streptokinase. And so that one was, I think, a super interesting trial. But yeah, it had nothing to do with oncology, but just on how we think about things and health policy and clinical effectiveness.
For sure. For sure. Your favorite restaurant and a hiking spot in Arizona?
Oh, yeah. Favorite restaurant. We have a great place called Hero Sushi, which I really like. So if I guess I had one meal, that would be it. It's run by a family that's from Japan. They make their tofu in-house, and they just do as good a job as anybody out there. And I think my favorite hiking spot, I'm partial to Gateway Trailhead. I like it because it can take you to a lot of different places, and parking's never a problem. Like if you go and try to hike Camelback. A bigger challenge in hiking Camelback itself is getting parking to access the trailhead. So I think the best kept secret is Gateway Trailhead, because great views, great hikes, a lot of options for beginner to advanced, and huge parking lot. So never a problem finding parking.
That's a robust tip. Thanks for sharing that with our audience. Wonderful. All right, Samir. A fun fact about you. So you are a very good cook. Do you want to share some anecdotes around cooking and yourself?
Yeah, it's funny. I took a cooking class because I didn't get into a first choice option. I think it might have been typing. I can't remember, in middle school. So they had an opening in a cooking class. So I took it and I really liked it. And it's a great life skill. And so I learned how to make a few things. And so it's relaxing. I make a pretty good eggplant or chicken parmesan. I make I think a pretty good apple cobbler, and you can make those really healthy, believe it or not. And so that's what I like to do. So when I have some time, and usually around the holidays, like next week is Thanksgiving, so I'll probably make a tray of eggplant parmesan or chicken parmesan, or maybe even both. And certainly when you come into town.
Yeah, absolutely. We have to have dinner with you and your family. Wonderful.
That we would be honored.
Yeah. Aw. Samir, if you have to relive your life, if you were to relive your life, would you choose radiation oncology? This is the last question for the day.
I would, without a question. I think we have a great feel. I don't know anything differently, but I certainly don't regret my career choice. I think it's an honor and a privilege. I remember one thing I learned in med school from a mentor. It's an honor and a privilege to approach the bedside. It's a great field. I think we provide value. I think we can help patients both in the curative setting and especially in the palliative setting. I mean, we really can those are tough situations, but we can actually make end of life much more tolerable for patients and help them with a difficult time and dignity and managing pain. And so I think the palliative aspect of radiation medicine is as rewarding as the curative aspect.
Absolutely. Well, thank you so much, Dr. Keole. So the 3 key takeaways for our oncology community from Dr. Samir Keole's conversation: advocacy in radiation oncology is just as critical as it is in any other field of medicine and medical oncology. So all the radoncs out there, please start advocating and get engaged with policy if you're already not doing that. Number 2, AI is here to complement and augment as to what we're already doing. So I think it's really important that we start embracing it and we start kind of investing in it, really our time and efforts, because nothing is perfect when it gets started first, right? And we all have to kind of hone it further and improve it further. And it's best improved when we partner with it and collaborate with it. And last but not the least, take a moment to just breathe, guys. Appreciate the little things, appreciate your family. Please step back. I think this is the perfect time to say that, because next week is Thanksgiving. So please slow down and just appreciate life. That is a great tip right there. Thank you to our viewers and listeners. This is Jasmine Kamboj and Dr. Samir Keole signing off on behalf of OncoDaily from our conversation on Empowering Oncologists. And now we have an Empowering Oncologist playlist on YouTube. Don't miss an episode and stay tuned. Thank you so much, Dr. Keole. I really appreciate our conversation. Thank you.
Thank you. This is fun.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.